President Frank, the 21st president of the University of New Mexico, has joined us this morning. President Frank comes to the university most recently from Kent State, where he was provost. But the important thing, I think, is that he is a native New Mexican and is a graduate of the University of New Mexico. As an undergraduate, a master's student, and a doctoral student in the psychology department, certainly one of the departments we work closely with at the RWJ Center. And as a psychologist, and also having founded the School of Public Health, or the College of Public Health at the University of Florida, he certainly brings an interest and an understanding to the issues that we're trying to address in this symposium. So let me invite President Frank to say a few words of welcome and other thoughts.
Thank you very much, Bob. It's a real pleasure to be here. I assure you I am the president of the university, and I'm pleased that I am the president, very pleased. But I'm here totally in my own personal selfish interests here. When you're a president of the university, you spend an enormous amount of time focusing on the university, as well you should. But every now and then you like to do something that you're interested in, and health policy is something I'm very interested in. I spent 5 years working in Senator Bingham's office on health policy issues, and during that time it was one of the sweetest periods of my life, because I got to learn and do something that I felt was very important for New Mexico, and do things that you felt made a difference. And so when Bob graciously invited me to come, we looked at my schedule to see if I could be here for your whole conference, and at the end of the conversation they said I could come for 1 hour, 8 to 9. So I'm here. This is the hour that I could come, so I'm here to hear one great talk, and I'm delighted. This is actually a topic I'm interested in. When I was at Florida, we did some work in this area, so I'm here to listen and just enjoy a throwback in my life. So I'm pleased to be here. I wish I could have been here for the whole time. I'm thrilled with the work that this center does on this campus. One of the really great things about coming back to New Mexico is each day, as I work on something, I find all the rich things we do here that we don't tell the world about very much. This center does get some attention because it's a great center in a state that has tremendous needs around healthcare. So we get a little more attention to what we do here, not nearly equal to the quality of this center. But the University of New Mexico has faculty, as you all know, that do tremendously high quality work in a state that has tremendous needs, and we're not very good about bragging about ourselves. We brag about this center a bit, but we need to brag much more about the quality of the work of our faculty. So thank you for letting me join you for this 1 hour, and I'm going to listen in the back, and then I'll have to slip out, but I appreciate being here, and congratulations on the quality of the seminar you've put together. It's extraordinary when I look at the contents, and thank you for letting me join.
This morning it is my great honor to introduce Dr. Ponce. She is an assistant professor in the University of California, Los Angeles, Fielding School of Public Health, Department of Health Services, and associate director of UCLA's Asian American Studies Center. She received a bachelor's degree in science from UC Berkeley, a master's in public policy from Harvard University, and a PhD in health sciences from UCLA. She is an expert on health insurance, economics, and racial and ethnic health disparities. Her research has focused on understanding macroeconomic effects on health and healthcare access in low-income neighborhoods and among racial and ethnic groups in the U.S. In preparation for the symposium, I spent the past 4 months familiarizing myself with her work, and I found it incredibly inspiring. In reading her work on the role of residential segregation in the maldistribution of primary care providers, and also her work on the contributions of healthcare market structure to racial and ethnic screening disparities, I have reached 3 major reactions. 1, this is fantastic. 2, how can I apply this framework to urban American Indians? And 3, oh, I really should have studied economics. In addition to her wonderful body of work, she recently received the Royal Morales Community Service Award from UCLA Filipino Alumni Association. In 2008, she was voted Outstanding Professor by the UCLA School of Public Health Student Association, and in 2009, she received the Dean's Distinguished Professor Award. Please join me in welcoming Dr. Ponce.
Thanks, Dr. Heiser. I am not a morning person, so, and especially since it's a little bit earlier in California. But I'm so happy that all of you are here this morning and just marveling at what a wonderful group of scholars that you have here. Bob, thank you. I was up late last night changing some of my slides because actually Bob was my former teacher. And I think you taught the first class that I had at UCLA. And so, so in honor of Bob, no pictures from the past though, that's good. But remember yesterday when he, and I'm not sure if everybody was still awake or was just starting about this time, 24 hours ago, Bob had a slide on distinguishing between the use of the term inequities versus inequalities. And so I had it all wrong in my slides, so that's what I did. And again, this is my honor to you. I appreciated the talk, the reference to transdisciplinary research by Sarah yesterday about having a fight with an oncologist and a tumor biologist, and then leaving, and then was so upset that it was so cold in Chicago she forgot her coat, but it was really, really, very exciting for her. I kind of do the same thing. I have an office at the UCLA Asian American Studies Center, which, if you're familiar with UCLA, is in North Campus. It's a beautiful part of campus. There's a sculpture garden, film is there. Everybody just seems very inspired in that area. And then I walked to the Fielding School of Public Health, newly named Fielding School of Public Health, which is sort of South Campus. Everybody sort of still looks inspired, but a little bit not as artsy. And then I walk further off campus to Wilshire, which is officially off campus, which is great because we get a better indirect rate there. And that's where the UCLA Center for Health Policy Research. So I chose to wear the UCLA Center for Health Policy Research because it is my recent new home. I'm returning to it. I'm returning as I was the co-principal investigator of a major survey there called the California Health Interview Survey, and I've returned recently as the principal investigator. I've spent the summer there, and it is all the conversations we had yesterday about how do you make your work have policy impact, how do you make it translational, how do you get beyond the peer review. I think this is the place where it's happening. So because of that, I decided to just start off with structural inequities in U.S. healthcare system and with the UCLA Center for Health Policy Research. And most of those people there aren't really real people, they're people that work at the center. So, one of them my RAs. So the agenda is that it's 4 parts. It is akin to what Vanessa Gamble said yesterday. You want to study, you want to investigate, and then you want to solve. And I don't know if we could do that today in this talk, but it's organized this way. First, an introduction on the link between structural inequities in healthcare, and then looking at some examples from my recent work and some work that's brewing. This is work with Dr. Michelle Coe, which is the article on residential segregation in Fqhcs, plus a forthcoming article that I'll have to share with you. I couldn't share with you for this talk, but it's actually a chapter for the book Changing the U.S. Healthcare Systems that my department puts out. And then some new and current work on income inequality and access to genomic tests that I'd like to share with you. We want to look at policy frameworks today. This might be a review, but so I'll check around. I do like to also call on people if that's okay. That didn't happen yesterday, so I do like to be more interactive because partly I don't know the answer, so I'm going to look to you to help me out, and then some mechanisms and pathways that I've been thinking about how structural inequities work through the healthcare system that produce these inequities that we see in health. and then a call for policy action, which is a little bit of an overstatement because most of us here are academics, but it's a call for evidence. I'm not going to say evidence-based, but for evidence that can help formulate policies, that could guide policymakers to formulate policies that can solve some of these inequities. So the link between structural inequities and healthcare. Starting out with definitions, as I was taught from Dr. Valdez. There's lots of definitions, and you've probably seen the WHO Commission on Social Determinants of Health. This is more of the lay definition, what you would say at a dinner party. What are structural determinants? Like you wouldn't say social stratification, you know, but you would say it's about giving every person the chance of leading a flourishing life, or as Sir Michael Marmot says, you know, giving every kid a chance. It's not just about healthcare access. It's also outside. In fact, it is almost supremely outside the healthcare sector. It's about schools. It's about your job. It's about commuting to work. It's about your leisure. It's about your homes. It's about whether you can walk safely in your neighborhood. But structural inequities, though, which is, and I had to really understand this in reading the WHO document, because it's about the social determinants of health. It's not a framework of the social determinant of health inequities. So it's the social determinant of health. So presumably, if a society is, or back to Dr. Levy's in the slide, imagine, right? So if the society was not inherently unequal, then this really would just be social determinants of health. It wouldn't be social determinants of health inequities. But because it's unequal, then purportedly what we're really looking at are these social determinants that produce, generationally yield health inequities. And structural inequities, again, back to the dinner party, well, it's about power. It's about the balance of power, the balance of who has the money, who does not have the money, who has, as an economist, goods and services in this market. And in the WHO perspective, it's globally, it's nationally across different countries, and in the United States, it's about within our communities. So why does it matter, these structural inequities, and what's the evidence? And I'm not sure WHO did this, but I think they have a lot of, you know, smart minds there and big thinkers. They estimated that about half of ill health around the world is due to these chasms, these divisions, stratifications of those who have and those who have not, those who are advantaged and those who are disadvantaged. But what about the United States? So we're a little slow in the United States in being on the program with social determinants of health, but it's been hitting the literature for over 30 years. So this 2011 article by Galea and his colleagues at Columbia at HAPH did some fancy meta-analysis, like looked through the literature from 1980 to 2007. And with this meta-analysis, then identified that with an estimated about 2 million deaths in the United States during this period, that portions of these deaths were attributed to these social determinants. And most of them actually are because of, what do you think would be number one? I know you can't read this, that's why I can ask. Oh, I haven't been advancing. That was the picture, you know, of social determinants, structural inequities. It's a picture of San Francisco, my hometown. I'm not sure where that's from. Probably still in San Francisco. And, okay. So you really couldn't have seen that slide if I hadn't done anything. All right. So what about the United States? So Galea looks at all these studies. I think there were over 40 studies, 47 studies. And again, for those way in the back, I'm going to ask Frank, because he's way in the back, he hasn't left yet. What do you think is number one for individual determinants? You're cheating. Homicide. Oh, homicide. Oh, no, you're not cheating. No, wrong. No. You kept ramming this to us yesterday. It's education, right? So education is number one among the individual level factors, and I think I can do this. Low education, it's 244,000 of the about 2 million, so over 10% of the deaths attributed to low education. Of course, there's always poverty. And then low social support also made it. There were some others, but these were the top three. But again, as we were reminded yesterday, context matters, and this is really the subject of my talk, is looking at area level social determinants, what I'm calling the social processes that arise from these structural inequities. And for area level, we see neighborhood poverty, 39,000 deaths. Income inequality is implicated for 119,000 deaths, and racial segregation tops it. It's attributed to 176,000 deaths. So these are just numbers, and in a policy framework, you've got to, I think I remember in my MPP program, you have to say, acid rain, what's the big deal? It can save 4 fish. So you have to then benchmark it to something, or are those numbers, do those numbers really make a difference? Well, those numbers, yeah, those numbers are comparable to the number of deaths caused by acute myocardial infarction, cerebrovascular disease, or lung cancer, the leading causes of death in the US today. But most studies, though, link structural inequities with ill health and mortality. Fewer link this with the healthcare system. So start with an example, and then we'll start with a framework. I'm kind of working backwards, but let's start with the example and then do the framework, because sometimes the frameworks are easier to go through after you have an example. My article on community residential segregation is one input to the healthcare system, the local supply of Fqhcs. So community residential segregation, as defined by Massey and Denton, is the degree to which 2 or more groups live separately from one another in different parts of the urban environment. And this is 2 counties. This is Los Angeles and Orange County. The borderline is somewhere around here. If it's all blue, it's mostly the white population. And then if it's all yellowish, it's mostly the Latino population. So Los Angeles is basically a white-Latino divide. There's some speckles of the African-American population in this area here. And the Asian population is a very light green, very hard to see, but there's some areas here that are Monterey Park, Alhambra. If you ever go to LA, you'd go there immediately to have dim sum. And then this area here, again, African American population, very concentrated. So Los Angeles is an example of a very segregated county. I don't know much about Orange County, but it does look like it's mostly white. And in the upper part is Latino. There is a little bit of green here, and I believe that would be the Westminster area with the mostly Vietnamese population. I'm sorry, and I think this is Catalina. So, one way of measuring residential segregation is through a dissimilarity index. And how many people are familiar with the dissimilarity index? I know there's a lot of sociologists here. What's the problem with the dissimilarity index? And I do use it. In fact, I am going to use it. I guess the hint would be in a multi-racial population. So here it's mostly Latino, white, but when you're looking at, but there's still some larger populations. So if I just looked at this chunk of Los Angeles City, I then do have not just Latinos and whites, but I will have Latinos, whites, and African Americans, and a bit of Asians. So the dissimilarity index is best for just comparing 2 groups. It's not really great at comparing several groups. Another is, and again, borrowing from field ecology, a diversity index. Not many people will use it. I don't see it that much in the literature, but it's the probability that if you take one swath area that you would encounter 2 different species. So that would be the diversity index. I guess that could get at, if you're a more multicultural population, that might work. But the dissimilarity index is used quite a bit, and it's basically what would it take to move, to rebalance the area that you're looking at so that it's balanced. So would it take 100%, say it's a Latino white dissimilarity index. If it's 100%, would you need to move 100% of Latinos to other areas to get at a balance? What we want to look at as the input in healthcare are federally qualified health clinics. And federally qualified health clinics are located in areas that are called medically underserved areas. And so there are different criteria for that, but nobody's really looked at whether residential segregation is associated with this. And so how does residential segregation then contribute to the need for safety net primary care services that are provided by Fqhcs? Fqhcs, they're a critical source of primary care for disadvantaged populations in the United States. They have been since the 70s. They serve nearly 1 in 4 low-income Americans. Over 90% report incomes below 200% of the poverty level. Most, an overwhelming majority, are uninsured or covered by Medicaid. And they also serve racial ethnic populations. 35% are Hispanic Latino, 27% are African American. Oh, so this is sort of the stock photo. Oh, I'm sorry, I'm not used to this double, but this is the stock photo of a community health center. It looks very cute, very stock. This is a community health center I toured just 2 weeks ago in the Waianae Coast in the leeward side of Hawaii. I think that woke up some non-morning people. So, community health centers are looked at, as the last resort, but in many cases, especially with very committed activists, very community folk, that you create a place where you really want. This is the first place I'd want to go to. If I got sick in Hawaii, this is the first place. And this isn't even. This is, I think, the meditation room. This isn't. The Waianae Coast Comprehensive Center is enormous, and I'm not even showing the backdrop, which is a set of. Looks like Holly Mountains, if you've ever hiked in Kauai. Really beautiful mountains behind it. Very comprehensive. They serve predominantly Native Hawaiians because that part of Oahu is mostly a Native Hawaiian enclave. It's a very poor enclave, but the folks that, the community, the social capital was so strong that they created a health center that also works with complementary and alternative medicine with Native Hawaiian medicine. And so it's a very beautiful place. So how does residential segregation then, how could it contribute to the need? And I'm using the word need. In my article, I went back and forth with the reviewers because they kept saying, well, don't you mean supply? Don't you mean supply? Why do you keep saying need or demand for primary care services? And so, we compromised. I think the title has the word supply, but I think we inserted need in different strategic places in the discussion because we really think it is more about the need. There are multiple potential mechanisms. Now, where the confusion is in thinking this through is we do think the need arises from a supply, from what happens with the supply, or the pathology of the supply. The need happens because the potential mechanisms are that maybe there's geographic segregation between the providers and the patients, so that doctors, clinicians, other providers would not live in the same neighborhood as an underserved community, or may live very far away, and there are disincentives to go to this underserved neighborhood. Maybe it might be because of physician preferences. There's a lot of studies the last decade now on differential treatment from the unequal treatment report from the IOM. Maybe physician preferences are that they don't want to serve this kind of population. Or maybe they do want to, they're very well-meaning, but they just aren't paid well enough. So the physician incentives aren't there. And since Medicaid pays most of the for this population, the Medicaid reimbursement rate might be too low to attract physicians to work in these groups. So it's a supply. The problem is the supply, but we still argue that the need, that how these community health centers come about still comes from the need. Our approach, so we use the area resource file, 2000 to 2007. It's readily available. It's linked with the 2000 US Census on US metropolitan counties, but also known as core-based statistical areas, or CBSAs, an 8-year period of FQHC expansion under George Bush from 2000 to 2007. We tested the hypothesis that residential segregation by income and residential segregation by race ethnicity. So here, residential segregation is not just about what we normally call race ethnicity, but also about income. So it's income and race segregation, if it's associated with the local supply of FQHCs. The segregation measure was a dissimilarity index. I'm going to show you just the main results here. What we looked at was the non-white dissimilarity index, the poverty dissimilarity index, and then put in the medically underserved area or piece population criteria in setting up, in establishing an FQHC. And that includes, and actually that's up for question if this criteria should be updated. For example, I mean, there's poverty rate, there's number of physicians per 1,000 populations, there's infant mortality rate, percent over 65 years old, but it doesn't have, say, something like percent immigrant population or percent LEP, which has been argued with HRSA. It's also population in thousands to get at the volume increase. So of course, we want to control that. Of course, there's going to be more FQHCs for those years because the population increase. And then a base number of their starting point, the number of FQHCs in 2000. This model is just any new FQHCs between this period of 2000 to 2007. Again, this was a period where President Bush did put money in scaling up FQHCs, building new FQHCs. That using this is the odds ratio, which I actually hate, but I'll talk about that later. And so, main thing is to look at the stars. I worked with epidemiologists who were so anti-stars, they did not want me to ever put significance levels in stars, and be thinking again about this transdisciplinary approach, but just looked at the confidence intervals. But the 3 stars are very significant, P of less than 0.001. So the poverty dissimilarity index was significant. The non-white was not, so it was dropped from this analysis here. And it looked like poverty rate is a good criteria. It's related, but number of physicians was not related for having any new FQHCs. Neither was infant mortality rate, neither was percent over 65 years old. Of course, population in thousands mattered. Starting point didn't really matter. So then we go on then in modeling whether if they had at least one FQHCs, the expansion from 2000 to 2007, and of the 1757 counties, metropolitan areas, 526. In this case, we use a negative binomial model, and this is an incident rate ratio. It's basically, it's a count model. And we do start to see the significance of both the non-white dissimilarity index and the poverty dissimilarity index. Poverty rate, again, has a robust association. Now, number of physicians per 1,000 residents is robust, but it's in the positive direction, so that the more physicians, active physicians per 1,000 residents you have, the more you're likely to have FQHCs. So it shows that there seems to be a supply response, a little counter for my argument that maybe there aren't enough physicians in that area, which then makes you think, well, if there are enough physicians in the area, then maybe what's operating then are the disincentives or the preferences. Infant mortality rate, again, didn't matter. Elderly population didn't matter. Population in thousands this, mattered, and the starting point did matter. So the reason why I don't like odds ratios and IRRs is you don't have a sense of the magnitude of these effects. So here, we then, sorry. Not as fast as Bob yesterday. So here we see we do a predicted probability. We chart this, but we actually have the estimates with bootstrap confidence intervals. But this side of the chart is the poverty dissimilarity index. So this is the inequities by income, and this side of the chart is inequities by race. So they're both what we call residential segregation, but this is income and this is race. And in income, and going from left to right in the horizontal axis, it's more inequitable. It's more, there's more segregation going on here. Same thing here. But it shows that the higher the segregation by poverty, that you do have this increase, and I'm going to say demand for FQHCs. This is again where the reviewers are saying, you mean increased supply for FQHCs. And I think maybe Ben's going to discuss that. But you have this increased demand, and we just looked at it as low poverty and high poverty as a comparison, where the high poverty areas had more, which made sense. For race, we see the same. It's a different nonlinear relationship. The curvature seems to be that there was a takeoff, that the higher the segregation by race and ethnicity, that this goes up quite rapidly, and it doesn't plateau or level off as it does for the poverty. So why do you think that would be the case? So it seems like there is a demand, that inequities do increase the need or the demand for these safety net services, but the mechanism, whether it be income inequality or be race ethnicity inequality, is different. There seems to be this plateauing effect. So what we think that's going on here is that for income, that these very extreme levels of segregation in income, do you think that these are areas that are rich or that really poor? I'm hearing, sorry?
Probably both.
Probably both. We looked at this, and actually most of these were richer. Most of these areas were richer, and in fact, what you think that before, when you thought of income inequality with the Gini coefficient, it used to be saddled with the really, really poor countries, like in East Africa, have very high income inequality. Well, the United States income inequality is, I think, about 0.54, 0.55, again from 0 to 1, 1 being the worst, just only one person that has all the wealth. It's about the same as Brazil's right now. So for the United States, we have very high income inequality, and it's rising. And this 0.60 is about New York's income inequality. So it's actually wealthier areas. And so if it's wealthier areas, then I'm going to be charitable, and I'm going to say, well, perhaps in wealthier areas, that these areas then may have the resources, and it fits in their, what economists would say, their utility function, to then support FQHCs. Because if this levels off, that means something else is kicking in, because the need is increasing. So non-FQHC providers then seem to be providing some care, and we suspect that in these areas that there is this higher level that may be higher income level communities then might be able to support a safety net. For non-white dissimilarity index, however, for residential segregation for race, we're not seeing the same thing. And in those cases, we have kind of a different story. And the story here is that that these highly segregated ethnic enclaves, sort of in the absence of local providers, that the ethnic enclaves may actually have a supportive effect. And so that these ethnic enclaves then may spur the mobilization and advocacy efforts to start Fqhcs. And this is why I'm saying it's demand, because it's not that between 2000 and 2007, George Bush said, let's look at inequalities on the map in the United States, and then let's say, okay, so let's put Fqhcs over here versus over here. The allocation mechanism wasn't that way. You still had to have communities that had the wherewithal to get the application together to have all the evidence and documentation that you met all the criteria of poverty, et cetera. So that you needed a sense, at least a base of social capital to have this established. Hence is why our argument that it's a demand. And because this is happening for the racial segregation, that we think that perhaps there could be some social capital going on. And indeed, in looking at these communities, they are mostly communities that actually have an increase in the Latino population. So what are the policy implications? Well, there's broader social policies, obviously, because it's broader social policies that that reduce, eliminate these inequities in racial segregation and in income segregation. But in the absence of this, it does look like the demand for safety net services that related to this may increase in the near future. And the demand for primary care services is expected to rise. Because with the Affordable Care Act, you have 16 million Americans who will gain coverage through Medicaid expansions. So we need to generate understanding of these downstream implications of the urban development, social welfare policies, and health services. So now to the framework. So this, I believe you've studied in your coming up to the symposium. This is the WHO Commission on Social Determinants of Health. This is revised. This is by Solar and Irwin, 2010. It was recently revised with the Rio conference. And the structural determinants are key here. They're this large orange L. Then there's also intermediary determinants, and so the socioeconomic political context, governance, macroeconomic policies, social policies, public policies, culture and social values, or the a community's taste for having good health. And then there's socioeconomic position, but in this framework here, where's the healthcare system? Or how big is the healthcare system? This framework here, the healthcare system is tiny. It's right here. So again, the social determinants of health are supreme in this framework that the WHO puts forth. And in this framework, it is an intermediary determinant of health here from the socio-economic political context going into the health system. Why is the health system so tiny in this? Globally? Well, since it's the health system in low-income countries, you might get more bang for your buck in investing in education for girls than necessarily investing in the health system. So that could be one reason. And then for countries that have the same income as the United States, like OECD countries, well, they have universal coverage or near universal coverage, so perhaps the health system does not necessarily come into play. But in the United States, with the inherent inequities in our society, and the fact that we weren't insured, we didn't have universal coverage pre-ACA, then social determinants are really important. Another framework is the Robert Wood Johnson Foundation Commission to Build a Healthier America. And here it focuses on the United States, where the RWJF Commission explicitly recognize that medical care is also inherently embedded into social context. In the WHO framework, it was an intermediary determinant. It wasn't embedded into structural inequities. In the RWJ framework, it's part of the context. So here, RWJ's vision is it's a rainbow. It's a black-gray shades of gray lane. It's kind of a gloomy rainbow, but it is a rainbow. And but it's asset building. It's how do you build a healthier America? So it's not to look at inequities. It's how do you build up. But there are these, the rainbow kinds of, you can go directly to health from context. So this is sort of the thinking in these conceptual frameworks is there seems to be more of this reverberating argument that it's through context that leads to health. Not so much that the pathway goes through medical care. So that the, economic and social opportunities and resources could lead to better health or worse health. Living in working conditions could lead to better health and worse health. And then you have the black boxes of medical care and personal behavior kind of together in tandem, and they could also lead to health. They're nested, and so it primes us to perhaps a multi-level modeling assumption. They're nested within the context, but we still don't know the pathways. This is just sort of the organization, the hierarchy of how we get better health. So the linkages, though, are not clearly understood. And the sources of the social determinants of health occur over time and space, so that tracking exposures over a lifetime across different places where the individual works and lives presents a major data challenge. I don't know of any perfect data, secondary data out there where we can get this. The factors are difficult to observe also, so it's not just things are changing, not just people are changing over time and neighborhoods are changing, but they're also difficult to observe because we don't know how the individual copes with social stressors, how well an individual harnesses the assets in a neighborhood that modifies the extent that SDOH impacts health. So the mediating factors such as the availability and quality of health care then may link this relationship, and that's what we're submitting, between SDOH and health. And this has to be better understood, and it has to be better understood because all of us are health services, well, I'm a health services researcher, and so it's through the healthcare system that I understand best, that I want to understand